Today I'm going to present on CVA, and my portion is anatomy, and the history taking and portion will be Dr. Mukesh sir. There are two paired arteries which are responsible for blood supply. The first which is anterior circulation, and the second one the vertebral artery, which forms the posterior circulation. Within the ball, the 12 branches of this artery forms an anastomotic circle called the circle of Willis. This is a picture. This is a picture showing internal carotid artery and which forms the anterior circulation, and vertebral artery which forms the posterior circulation. An internal carotid artery, it originates at the bifurcation of left and right common carotid artery at the level of C4 cervical vertebra. There they move superiorly within the carotid sheath, and it enters the brain via carotid canal of temporal bone. The internal carotid artery do not supply branches of face or neck. In the cranial cavity, the internal carotid pass anteriorly through cavernous sinus, which and distal to the cavernous sinus, it gives the following branches. Number one, ophthalmic artery, which supplies the structure of orbit. Second one being the posterior communicating artery, which acts as a connecting vessel in circle of Willis. Similarly, the third, anterior choroidal artery, which supplies structures in the brain important for motor control and vision. And the fourth one being the anterior cerebral artery, which supplies the part of cerebral. The internal carotid artery then continues as middle cerebral artery, which supplies the lateral portion of the cerebrum. Similarly, on posterior circulation, it is formed by vertebrovascular artery. The vertebral artery, the right and left vertebral artery arise from subclavian artery, which lies medial to the anterior scalenary muscle. Then they ascend posterior aspect of the neck through the holes in the transverse process of cervical vertebrae, known as foramen transversarium. The vertebral artery enters the cranial cavity by foramen magnum. Within the cranial vault, some branches are given off as meningeal branch, which supplies the falx cerebri, anterior and posterior spinal artery, which supplies the spinal cord. Similarly, the posterior inferior cerebellar artery, which supplies the cerebellum. After this, the two vertebral artery converge to form a bacillary artery, and several branches from the bacillary artery originates here, and it supplies cerebellum and the bones. The bacillary artery terminates by forgetting into posterior cerebellar artery. This is a picture of USG of carotid artery. In the carotid artery USG, we mainly sees for any aneurysm, any stenosis, or any dilatations. To look for any cause of ischemia. Similarly, the circle of Willis, the terminal branches of vertebral and internal carotid arteries anastomose to form a circular blood vessels called the circle of Willis. There are three main paired constituents of circle of Willis: anterior cerebral artery, and this Anterior cerebral artery are the terminal branch of internal carotid artery, and internal carotid artery, which is located immediately proximal to the origin of medial cerebral artery, the posterior cerebral artery. It is a terminal branch of basilar artery. To complete the circle, the two connecting vessels are present: the anterior communicating artery, which connects the two anterior cerebral artery, to the posterior communicating artery, uh, which connects internal carotid artery to posterior cerebral artery. Similarly, for regional supplies of cerebrum, there are three cerebral arteries: the anterior cerebral artery, the middle cerebral artery, and the cerebral artery. The anterior cerebral artery supplies the anteromedial portion of the cerebrum. Similarly, the posterior cerebral artery supplies both the medial and lateral part of the cerebrum, whereas the middle cerebral artery is situated laterally and it supplies the majority of lateral part of the brain. This is a picture. This is a schematic picture and MRI picture, which shows the distribution of middle cerebral artery. There are middle cerebral artery. The middle cerebral artery uh, at the level of M1, it gives several deep branches, which are called as lenticular-straight vessels, and most of the lacunar infarct usually occurs at this place. Similarly, this is a diagrammatic representation of lateral aspect of brain. In this, we'll mainly see for the middle cerebral artery and its branches. Middle cerebral artery divides into superior middle cerebral artery and inferior division of middle cerebral artery. This inferior cerebral artery gives the branches as anterior temporal artery, similarly posterior temporal artery, angular arteries, and posterior parietal artery. Similarly, the superior division of middle cerebral artery gives the branches to as lateral orbitofrontal artery, Rolandic artery, and anterior parietal artery. Similarly, it supplies the inferior division of middle cerebral artery. It supplies to the areas of it supplies to auditory area, similarly Wernicke's area, and to visual center. Similarly, the superior division of middle cerebral artery, it supplies to the sensory cortex, motor cortex, and the Broca's area. So if uh, there is obstruction in inferior division of middle cerebral artery, it will lead to sensory aphasia. Whereas if the superior division of middle cerebral artery is involved, it will lead to motor aphasia. Similarly, if middle cerebral artery is involved, if there is any pathology, it will lead to global aphasia. Similarly, we will discuss about a case. This case was had presented week back in our emergency department. It is a case of 35 years female. She was a known case of stroke. She had history of stroke years back, and since then she has motor aphasia. with right-sided weakness. You can see there is area of ischemia at the left frontotemporal region. Similarly, this is a second case which we saw 3 days back in our emergency. She was 86 years female with known case of diabetes mellitus with hypertension, with seizure disorder, with atrial fibrillation. She presented in our emergency with complaint of, and when we did her CT scan of head, we saw a cerebral edema in frontal as well as temporal region, and she was a case of motor aphasia. And the middle cerebral artery is divided into four. Surgically, it is divided into four segments: the M1, M2, M3, and M4. The M1 segment is called sphenoidal segment as well as horizontal segment. It travels almost in a horizontal fashion from internal carotid artery to the point of middle cerebral artery bifurcation between temporal and frontal lobes. It is situated in sphenoidal part of Sylvian fissure. At the site of termination of M1, the trunk of middle cerebral artery takes a 90-degree turn into the posterior superior direction. Here, the middle cerebral artery is it divides into superior and inferior trunk. The second one being the M2, it is also called segment. It begins at the at point of MCA bifurcation. This segment starts within the genu of MCA at the level of Lyman insulae, and then travel along the surface of insula. It terminates at the level of circular circles of insula. Similarly, the third one being the M3, it is also called opercular. This segment causes over the inner surfaces of parietal and temporal of insular operculum. The fourth one being the M4 segment. It is also called cortical or terminal segment. It, it is the continuation of M3 segment. Once it emerges through the lateral fissure to reach the surface of the brain and travels over the surface of cerebral hemisphere. And the significance of this segment is that the horizontal segment, the M1, it is responsible for supplying the blood to basal ganglia. So, and it is responsible for involuntary movements. Similarly, the Sylvian segment, it supplies the blood to the temporal lobe and the insular cortex. Since the temporal lobe is involved in processing of sound, the insular cortex it regulates some motor function and helps in paired emotions and expressions. Similarly, the cortical segment it provides blood to the cortex, and this is sitting, and this case had presented 2 weeks back in our emergency department. We can clearly see that the right comparing the both segment of middle cerebral artery in the right on the right M2 segment is comparatively no comparison to the left segment. Reason is most probably in M2 segment of on the right side. This is the picture showing the anterior and posterior cerebral artery. Since the homunculus of the brain shows if the lesion is in motor cortex or medial Rolandic area, And if the patient present with weakness of limbs, the most probably the anterior cerebral circulation is involved. Similarly, if the patient presents with uh, visual symptoms or vertigo, most probably the posterior cerebral artery is involved. This is a picture of vertebrovascular circulation. As told previously, that these two vertebral artery, uh, these ascent and the two vertebral artery, and it enters through foramen transversarum, and it enters in the cranial cavity via foramen magnum. These two vertebral artery have converged to form basilar artery, and several branches from basilar artery here are going to supply the cerebellum and the bones. The basilar artery terminates bifurc- uh, by 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 bifurcating into posterior cerebral artery, and these structures are responsible for consciousness, coordination, and vision. This is a schematic picture showing the um, uh, posterior circulation of brain, and the MRI picture as well as which is showing the vertebral artery and basilar artery. Thank you. Now I would like to give now the now I would like to give the floor to Dr. Mukesh Kumar sir.
Good evening, respected faculties, my dear colleague, junior participants. This is Dr. Mukesh Kumar Shah. The part of history taking in a case of stroke. हजुर सबैले अहिलेसम्म एनाटोमिकल पार्ट को बारेमा जानकारी लिनुभयो। त्यो एनाटोमिकल पार्ट को पर्टिकुलर एरिया इन्भल्भ छ भनेर थाहा पाउन हामीले हिस्ट्रीबाट केही प्रयास गर्न सक्छौँ कि भनेर हामी इन्फर्मेसन दिन कोसिस गर्नेछौँ। बिरामी इमर्जेन्सीमा आउँदा, if any patient visits emergency with some particular problem, is this problem is traditional one related to stroke, or it is not related to traditional one related to stroke? Some those who presents in emergency room are very clear-cut features, but some symptoms are always difficult. So this feature is related to stroke or not, we have to judge this. If we go clinically and find that it is related to stroke, then our management plan can be changed. So it is always important to find out the symptoms appropriately. Among these, some symptoms which looks very simple, we miss them and we plan to discharge the patient from here, but it may be related to stroke. So those symptoms which looks very simple must be evaluated carefully to rule out stroke cases. So I'll focus on these things. So what are those traditional symptoms which are generally present in the stroke patient? One is the sudden numbness or weakness of face, arm, or leg. And in most of the cases, unilateral. But in some cases, it may be bilateral. Patient may present with the sudden aphasia. Patient may present with the sudden dysarthria. Dysarthria, in this case, the patient cannot coordinate the work properly. Another term is aphasia, there is an absence of sound. So they cannot speak. But there is two options if a patient do not speak. One is there is a loss of sensory area where the Warwick's area is damaged. At that time, what happens? The patient cannot understand the word, and so that, but he can reflect the words. He can speak. So यस्तोमा के हुन्छ भने बिरामीले कुरा बुझ्छ तर एन्सर दिँदा चाहिँ कुरा बुझ्दैन, सो उसले एन्सर दिँदा चाहिँ अर्कै एन्सर दिन्छ। जस्तै तपाईँ के गर्दै हुनुहुन्छ, उसले जे काम गरिरहेको छ त्यो नभएर अर्कै एन्सर दिन सक्छ। So in dysarthria, patient deviates from the proper word, but in aphasia, patient cannot speak properly. Another is the patient understand what is the question, but he cannot reply because he cannot. His motor part is lost. So Broca's area, there is effect in the Broca's area. So patient may present with such symptoms. Another is the sudden memory deficit or spatial orientation or perception difficulties. Another is sudden visual deficit or diplopia, sudden dizziness, gait disturbances or ataxia, sudden severe headache with the no known cause. These are the traditional symptoms, and we generally found these symptoms in the patient, and at that time we can say that this is the patient of stroke. But if the patient come with some other symptoms like the impaired consciousness or syncope, generalized weakness, altered mental status, dysphagia, shortness of breath, sudden pain in face, chest, arm or legs, seizure, falls or accident, sudden hiccup, sudden nausea, sudden fatigue, sudden palpitation. These symptoms may be mimicked with some other diseases also. So in these symptoms, we must be concerned and try to find out either it is the case of stroke or not. If it is a stroke, then our management is different. If something else, we will manage the patient accordingly. If such simple problems are managed with ER, patient can be discharged. But if the patient condition is related to stroke, then we have to think some different. So another, this is, in this slide, I want to show that a patient, 70-year-old patient, who presented in emergency room on day first, there is numbness of lower limb, increased dizziness on standing, nothing other than this. And the CT scan of day one looks normal. But the same patient on day two presented with the weakness of right upper and lower limb. And on day three, there is loss of consciousness. Then we aware about that. And finally, another CT scan was done. On day three, you can see here on the right side of the picture of CT scan, there is a hypodenseria on the left side. So patient, large hypodenseria on the left side. So this is suggestive of the ischemic stroke. So if we have evaluated the patient earlier on day two, then we can save the life of the patient. But we reached at the day three, and at that stage, patient get deteriorated. Unfortunately, we could not save the patient. This history, some history are very specific, so that we can differentiate the type of the stroke. Which type of stroke this is? Either it is ischemic or hemorrhagic. Among the ischemic, either it is embolic or thrombotic. So we'll concern today about either it is ischemic stroke or embolic ischemic stroke. How to differentiate them? So studying or waxing and waning deficit suggest a thrombotic or hypoperfusion related stroke. But if it is sudden onset of symptoms, suggest a embolic or hemorrhagic stroke. Another is a history of bypass or maneuver immediately preceding a thunderclap headache or sudden onset of symptoms suggest of a ruptured cerebral aneurysm. What happens? Patient has stent, and after that he develops severe headache. Then we must think that there is a rupture of aneurysm. We must think. So uh, we must concern about the severity, acuteness, severity of headache, acuteness, and uh, related changes in weakness of the limb are always important. History related to risk factor. By knowing the risk factor, we can guess that which type of ischemia is present there. So, if the patient has the history of hypertension, diabetes mellitus, and coronary atherosclerotic diseases, then at that time we can think that there is the thrombotic issues. So, thrombotic ischemia may be there. If the patient has cardiac issue like the fibrillation, valvular replacement, or a recent myocardial infarction, then we must think that it may be embolic stroke. I'll present a case here now. 53-year-old female presented in ER with catheter in situ. This suggests that patient must have visited elsewhere and then visited to our emergency room. Why she has given a catheter? Because she has incontinence of the urinaries. The catheter was placed 3 days back, but the incontinence was from last 20 days. She could not control the urge at that time. In last 3 days, she also unable to walk, and there was one episode of dizziness in last 24 hours. There is no history of headache, photophobia, no history of hypertension, diabetes mellitus, and cardiac issues. Facial deviation towards right was observed at emergency room, but there was no other neurological deficit, and all neurological examination except facial deviation was apparently normal. And their CT was not planned at emergency room. When you evaluate the case properly, we thought that, and it was for last 20 emergency. But when the patient was admitted in Department of Internal Medicine, in during round they planned for the CT scan, but CT scan is normal. But in MRI, what is seen that MRI is also done after CT scan. So MRI is suggestive of the features which are related to involvement of the left side is suggestive in the MRI. Here you can see that I can use marker. Yeah, here you can see that compared to left, this is the right side. Compared to the left side, there is a change in the this here you can see here. So blue mark is suggestive of there is some changes compared to the left side. This is suggestive that the ischemic or vascular changes, ischemic changes may be there due to the vascular change. So ultimately, this MRI is suggestive of is there vascular abnormalities? Of course, it was vasculitis. Still, we have to find out the cause of the vasculitis, but it is the major issue in that patient. So ultimately, ischemic problem and the patient was suffered from those issues. Now, if such problems are due to improper history taking, or we cannot evaluate those symptoms which looks like to the other disease, so it may be difficult or challenging for us in the emergency room, because in the short time we have to evaluate all those things. So in in the process of time saving at emergency room, we must rule out those diseases which mimics the stroke. So what are those? Then I'll show you some cases. If patient presents with the seizure paralysis, then we must think that this may be stroke, but it can be ruled out with supportive points that seizure is the transient paralysis following uh, paralysis in seizure is transient, and it typically disappears very quickly. But it may be confused with the transient ischemic attack. Another is the syncope. In syncope, what happens? It is not persistent and not associated with any neurological sign and symptoms. So symptoms, syncope is the transient loss of consciousness, and it is not persistent and not associated neurological symptoms were seen in case of the syncope. Meningitis and encephalitis are some other problems which also mimic with the stroke. But in meningitis, there is fever. And in meningitis is generally seen in case of the immunocompromised person. Complicated migraine. Sometimes severe headache is also seen in migraine, and severe headache is also seen in stroke also. So in migraine, there is previous similar episode. Preceding aura may be present, and headache mostly unilateral, but it may be bilateral. So we must rule out the migraine also. Brain neoplasm. Brain neoplasm, if it is focused and localized, then the neurological sign and symptoms are focal neurological loss. But there may be the mass effect due to neoplasm. So if the mass effect is there, then uh, there is changes in the intracranial pressure, and the sign symptoms related to raised intracranial pressure may be seen in such person. Epidural subdural hematoma. In the patient with the epidural or subdural hematoma, there must be a history of trauma, and in alcoholic patient, those who consumes alcohol, there is a chance of trauma in those patients. So we must ask history of the trauma in case of alcoholic patient. So there, if the patient is alcoholic and there is history of trauma, or patient is using anticoagulants, there may be chance of epidural or subdural hematoma. So this can be distinguished with the proper history of trauma, consumption of alcohol, and use of anticoagulant drug, is the patient is taking or not. Another is the subarachnoid hemorrhage. In subarachnoid hemorrhage, there is sudden onset of severe headache. In subarachnoid hemorrhage, the pain is so worse, the patient feels that it is the worst pain in his life. Another is the hypoglycemia. The patient, those who use insulin in diabetes mellitus, or alcoholic patient, if he do not take food, may present with hypoglycemia and at emergency, and it mimic with the stroke. A case I have seen in emergency room, a patient almost 53-year-old presented in emergency room, referred from another hospital as a neurological case. But on evaluation, we found that the patient is hypoglycemic, and with the correction of the sugar, patient get improved. But still there is issues, and we have solved those issues. Dyselectrolytemia, especially hyponatremia, may result in the neurological problem. If the sodium level is decreased more than less than 120, then neurological problem may develop. But mostly neurological issue are developed less at the less than 105. But it may be developed after 120 if the sodium is less than 120. So we must look at the electrolyte also. And in hyponatremia, in which condition the hyponatremia occur? One is the diuretic use, another is the neoplasm, excessive if the patient takes the excessive free water. Then similarly, hypertensive encephalopathy may mimic with the stroke. How we distinguish a patient with the persistent raised blood pressure may present with the neurological sign and symptoms, but we must think that it is the gradual onset. Patient have a headache also, and there is a raised BP for last few days. And all these features of the hypertensive encephalopathy is cumbersome with the stroke also. So at that time we get confused. Either it is hypertensive encephalopathy or stroke. Similarly, hyperosmotic coma in the diabetic patient where the blood sugar is high, then the osmolarity increases. At that time, the hyperosmotic coma may be present, and which mimics with the stroke. In ornix encephalopathy, those who are alcoholic, all consumption of alcohol and or the malnutrition, the patient may present with the ataxia, ophthalmoplegia, and confusion. So with this triad, we can guess that this may have the ornix encephalopathy. Thus, we can distinguish it from stroke. Similarly, labyrinthinitis, there is the vestibular symptoms may present, dizziness and dizziness or vertigo may be present if there is issues of the labyrinthinitis. Some drugs are responsible for development of the neurological signs. They are the lithium, phenytoin, and carbamazepine. So if the patient is taking these drugs, we must take the history regarding these drugs because it may be related with the neurological sign and symptom. So to rule out drug toxicity, we must ask the history of this lithium, phenytoin, and carbamazepine. Bell's palsy generally occurs in the young. What happens? This is a lower motor neuron palsy. But there is facial deviation, and it mimics with the intracranial issues like the ischemia or stroke. Similarly, Meniere's disease, in which there is the deafness, tinnitus, but it is the recurrent episode is there in the Meniere's disease. So with these histories, if there is tinnitus is present, deafness is present, and neurological signs and symptoms are present, then we must think that it may be Meniere's disease. Multiple sclerosis is due to multiple sclerosis is also related to neurological issues. So gradual onset, multiple sclerosis are generic. Gradual onset, multiple episode, and multiple anatomical distributions may be involved. So rule out multiple sclerosis also. And very common but challenging to differentiate. But we can differentiate a conversion disorder if anyone presents with the neurological sign or symptoms or looks like a loss of consciousness or abnormal presentation. But we must rule out the conversion disorder with the features like there is no cranial nerve in findings, no anatomical distribution of findings, inconsistent history by patient, and on examination finding also there is changes. So all these conditions, which looks very simple, but associated with the presentation with the neurological signs, but there is no true neurological issues, stroke, no hemorrhage. With this, I want to convey a message that if we take a history properly, we can follow the path proper to diagnose a case. So in case of stroke also, we must take proper history with all traditional signs and symptoms or non-traditional signs and symptoms should be evaluated, and the mimicry should be differentiated properly to find out the lesions and to find out the type of the stroke and to differentiate the ischemic stroke, that either it is embolic or thrombotic. Now, what is the benefit of the proper history then? If we know that the patient has the ischemic stroke and it is the thrombotic, then we can manage the patient at ER properly and save the life and decrease the mortality, morbidity, especially morbidity. So morbidity can be decreased with our at emergency room. So history of thrombolysis is in this slide explains that if the patient comes to emergency room within a 4.5 hour, we can treat the patient with the thrombolytic agent. His symptoms will improve and further deterioration will be prevented. For this, what should be known? The last known well time. It is the time at which the patient is normal. This means that he is normal at his or her baseline. His behavior, his sign symptoms are normal at that time. So before developing the symptoms, we must notice the time. And last known well time is not the time at which the patient regains his or her consciousness. So we must ask the patient properly that तपाईं बेहोस भएको समय थाहा छ या बेहोस भइसकेपछिको समय भन्दै हुनुहुन्छ? बेहोस भएर उठेको समय is different because we must know that at what time the patient was well, not the regain of consciousness. I want to concentrate on the point that this should be clear. So this term is the last known well time. We generally give the LT place in the patient of the thrombotic stroke. But we must know when the LT place should not be given. So if there is history of intracranial hemorrhage, it is absolutely contraindicated. Similarly, known arteriovenous malformation, head trauma or stroke in the previous 3 months, arterial puncture at non-compressible site within 1 week are the absolute contraindication for LT place in acute ischemic stroke. Some relative contraindication are here. We must look the risk, benefit and risk. If there is more benefit at this condition, we can give, but generally we do not give. What are those conditions? These are the pregnancy, rapidly improving stroke symptoms, myocardial infarction in the previous 3 months. With all this, I hope that with this presentation of 2 presenters here today, anatomical part and history taking, we must find out that either it is stroke or not. If stroke, which type of stroke is this? If ischemic stroke, either it is thrombotic or embolic. If it is thrombotic, can we give the LT place or not? If LT place should be given, it is ideal to give LT place in the patient or not. Is there contraindication or not? Not. And we can also know that which area of the brain is involved in this patient. I hope this presentation will help you all. Thank you. Thank you for participation and kind listening. Hazur. Sir?
Mukesh, Gautam, thank you. तिम्रो स्क्रिन शेयर एकछिन आउट गर. कसैको केही क्वेशन छ भने हामी.
सर म अभिषेक एउटा क्वेशन सोध्छु.
हजुर.
के रे मुकेश दाइ?
हजुर भन्नुस्.
अस्ति एउटा इमर्जेन्सीमा एउटा फिमेल आउनु भएको थियो हैन, 67 इयरको फिमेल है. हेलो.